You've probably seen one of those letters. We're writing to inform you your information may have been exposed. If that landed in your mailbox this year, you're not alone. Here's the thing. 2025 didn't have a single mega breach like we saw in 2024, but it still quietly exposed tens of millions of people through hospitals and their vendors. And if you work anywhere near tech or operations, the lesson going into 2026 is simple. This isn't a story about clever hackers. It's about predictable pathways and networks that haven't been reshaped for the world we actually live in. So let's set the table. We'll keep this practical. We'll talk about what actually happened, how these breaches work in plain English, and the 3 or 4 moves that change outcomes in 2026. Let's start with a human moment. When a hospital gets hit, it's not just IT's problem. Scheduling stalls, staff revert to paper, patients get confused calls about rescheduling and fraud alerts. The stress ripples through clinicians and families. Let that sink in for a second. Now, big picture. Across 2025, healthcare breaches affected roughly 42 million people. That's much less than 2024, but it's still massive. And a lot of it came down to 2 patterns. Ransomware crews focused on data theft, what analysts call pure extortion, and weak links through third-party vendors that hold patient data. In other words, attackers skipped the lock your systems part and went straight to we've copied your records, pay, or we publish. Here's what surfaced in late 2025 as year-end disclosures rolled in. Yale New Haven Health disclosed an incident tied to 5.6 million people. A vendor called Episource reported about 5.4 million. A ransomware group known as Medusa claimed data on around 1.27 million patients through a third-party vulnerability, boasting about hundreds of gigabytes of stolen files. Another provider later found an intrusion that had quietly sat in the network for months, touching nearly 2 million records. We don't have to catalog every case. The pattern is what matters. Credential-based entry, flat networks that let attackers wander, and large exports of sensitive files that fuel extortion. So, how does this actually work? Think of a hospital network like a building with too many doors and too few walls inside. The attacker doesn't need a battering ram. They just need one key left under the doormat, maybe a reused password, a phished VPN login, or a contractor account that didn't have multi-factor turned on. Once they're in, the inside is often open plan. File shares, application servers, and databases sit on networks that weren't designed with strict internal borders. That's where segmentation comes in. Segmentation means building interior walls. So even if someone gets into the lobby, they can't wander into the records room without hitting locked doors and alarms. Here's what actually happens most of the time. Step 1. Initial access through a phish, a weak VPN, or a vulnerable public system. Step 2. They move laterally, hop from one machine to another, because the network is flat and permissions are broad. Step 3. They find where the valuables live. File servers, backups, analytics data, and databases with PHI, the protected health information like names, dates of birth, diagnoses, and insurance details. Step 4. They exfiltrate. That's the data leaving your environment. They copy hundreds of gigabytes to cloud storage or an overseas server. So let's slow that down for a second. In 2024, the headache was widespread ransomware encryption. In 2025, the pivot was extortion without encryption. Steal the data, apply pressure. That bypasses your backup playbook. It weaponizes disclosure laws and headlines. And there's a second path that shows up everywhere. Vendors. Healthcare runs on an ecosystem. Billing firms, analytics providers, practice management tools, legal services. Many of these partners collect more data than they truly need and keep it longer than anyone remembers. Attackers know this. They go after the smaller gatehouse with a clear view into the castle. Here's a useful analogy. Imagine leaving your house key under the mat while all your valuables sit in a big open loft. That key is a leaked credential. The open loft is a flat network. Now add a side door that your contractor uses, the vendor connection. If that side door is flimsy, it doesn't matter how sturdy your front door is. So, what changes the outcome? First, data minimization. Collect less, keep it for shorter windows, and tokenize more of it. Tokenization is the practice of swapping a sensitive field, say, a social security number, for a harmless stand-in that only a separate system can map back if needed. If an attacker steals a token list, it's a pile of useless placeholders. Second, segmentation and least privilege. Least privilege means accounts only have access to what they genuinely need. It sounds simple, but it's the difference between an attacker hitting a locked door after one hop or roaming for days. Segmentation makes that roaming even harder by isolating workloads. Picture airport gates with separate checkpoints instead of one big terminal where you can walk everywhere. Third, watch the exits. If you assume some bad actor will get into a user account via phish, reuse, or malware, the next control is preventing large amounts of data from quietly leaving. That's where egress monitoring and DLP, data loss prevention, come in. It's less about blocking every file and more about noticing patterns. Why did this server, that never sends big files, just push out 500 gigabytes at 2 a.m. to an unfamiliar destination? Here's what matters. Prevention is great, but detection and containment shorten the blast radius. The playbook shifts from nothing bad ever gets in to if something gets in, it can't spread, and we spot it quickly when it tries to leave. Let's talk impact for a moment. Healthcare breaches aren't just about stolen numbers. Medical records are sticky. You can change a password. You can't change a diagnosis. That means identity theft can take weird forms. Fake claims, prescription fraud, insurance account takeovers, sometimes years later. Operationally, disruptions can push hospitals to paper, delay surgeries, and overload help desks. For leadership, it brings regulatory scrutiny and hard questions from boards. For clinicians and patients, it's stress in moments that are already stressful. So, why does this keep happening? A few structural realities: legacy systems that can't be patched without downtime, vendor sprawl where you inherit risk from dozens of partners, tight budgets and lean teams, and timing. Late December is a classic window when staff are thin, change freezes are on, and dwell time ticks up before anyone notices something odd. There's debate about tactics too, whether to build a big internal detection team or contract with managed detection and response providers. There isn't a single right answer. The point is to be honest about your coverage. If you operate 24/7 services, you need 24/7 eyes. Whether those eyes are in-house or a partner depends on your scale. Let's pin this to a few real cases from 2025 just to ground it. Yale New Haven reported a server hack that affected millions, but not financial data, so the doors weren't completely open. A vendor called Episource disclosed that ransomware hit systems storing medical histories and social security numbers. A Medusa claim tied to a third-party app highlighted how much sensitive data flows through these partner platforms. And one actor bragged about lifting 941 gigabytes of data. That's not a locked-down export. That's a truck. In other words, the breaches aren't mysterious. They're mechanical. That's good news, because mechanical problems have mechanical fixes. What's the outlook for 2026? Expect more of the same tactics. Ransomware groups will keep favoring extortion over encryption. Third-party incidents will remain a force multiplier. 0 days get headlines, but most compromises will start with basic credential abuse and misconfigurations. The key thing here is that the biggest wins aren't shiny tools, they're disciplined habits. Shrink what you collect, break your network into rooms, limit every door key, watch the exits. All right, if this applies to your world, here are a few practical takeaways worth considering. Right-size your data. Walk through one high-volume workflow and ask, what fields are we collecting? Where do they go? And how long until they're deleted? You'll usually find just-in-case data that can be trimmed. Less stored means less to steal. Put analytics on a diet. Dashboards and logs get treated like low risk, but they often mirror sensitive information. Apply the same access rules and retention limits you would for primary records. If your analytics tool were breached tomorrow, would you be comfortable with what's inside? Build interior walls first. Pick one critical domain, like clinical imaging or revenue cycle, and segment it properly. Separate VLANs, unique service accounts, and restricted admin paths. Prove the value in one area before boiling the ocean. Verify least privilege with a simple test. If a compromised receptionist account can read a bulk patient export, the model's too wide. Tighten by role, not person. Watch for quiet giants. Baseline which systems should never send large data volumes out. Then alert on any big change. It's a low-noise rule that catches exfiltration without drowning your team. Treat vendors like extensions of your network. That means contract terms for encryption, breach notification timelines you can live with, evidence of MFA and patching, and the right to reduce data sets they store. If they don't need full SSNs, don't send them. Plan for holiday and after hours. Build a lean night and weekend playbook. Who picks up the phone, what gets shut down first, and how to page legal and PR. Short and clear beats comprehensive and unread. If you're short-staffed, consider managed detection and response. It's not a silver bullet, but it fills the 3 a.m. gap many teams struggle with. Practice one painful scenario. Try pure extortion with stolen PHI. Not encryption, just data theft. See how fast you can confirm what left, notify the right people, and communicate clearly. It's a different muscle than restoring from backups. A quick word on cost and risk, because leadership will ask. The average price tag for a healthcare breach in the US lands in the high single-digit millions when you tally forensics, notifications, legal, downtime, and long-tail support. But the bigger hit is cumulative. Repeated letters to the same households, year after year. That's how trust erodes. If you're explaining this to a non-technical leader, try this framing. We're moving from a castle and moat security model to city blocks with friendly but firm guardrails. People still move around, deliveries still happen, but nobody can drive a truck straight through the archives at 2 a.m. Let's recap real quick before we land this plane. 2025's healthcare breaches were sizable, even without a single mega event. Attackers leaned into data theft over encryption, and vendors were frequent stepping stones. The attack chain is simple. One credential, a flat interior, and big exports out. Complexity isn't the enemy. Predictability is. The counter is structural. Collect less, wall off more, and watch the exits. Then drill the disclosure and response muscle, because the pressure game is part of the attack now. And if you do one thing this quarter, make it visible. Pick a slice of your environment, say, patient document storage, and tighten it end to end. Publish the before and after. Momentum matters in security. People follow wins they can see. Here's a closing thought. Hospitals can't change the fact that health data is valuable. What they can change is the shape of the network and the size of the reward. If a thief breaks in and finds tokenized fragments behind a series of locked rooms, the extortion story falls apart. If the only door that opens is the one that fits the job at hand, lateral movement stalls. That's not flashy security, it's just good architecture. Thanks for spending time on this. If you found it useful, a like and subscribe helps us keep making these videos.